Dear audience, dear chair, my name is Lőrincz, and my PhD thesis title is Impact of Uterine Surgeries on Clinical and Reproductive Health. I am a medical doctor and a full-time PhD student here at the Department of Obstetrics and Gynecology at Semmelweis University, and my vision are women without postoperative complications after uterine surgery, and my mission is to find uterine surgical techniques with the least amount of complications. To achieve my mission, I have two ongoing projects, and both of them are conducted as a systematic review and meta-analysis. So the first project is investigating the efficacy and safety of different cesarean section layering techniques. Cesarean section rate continues to rise globally, right now accounting for more than 1 in 5 of all childbirths. We can see that this number in Europe only is even higher, and it is estimated that by 2030, nearly a third of all births will take place via cesarean section. A complication of this procedure, which recently gets more and more attention, is the cesarean scar defect, which is an underestimated pathology and can have many complications ranging from infertility to placenta-accreta spectrum disorders, placenta previa, to the life-threatening ones like scar pregnancy, uterine dehiscence, uterine rupture. Single or double layer closure of the uterine incision remains a topic of debate, and clinical outcomes are lacking, so we need to find a solution for that. Here you can see the different types of single layer closure and double layer closure techniques, and also our aim, which is to compare different layering techniques and assess the complications in post-C-section women. Our clinical question is, does double layer cesarean section closure technique result in a lower incidence of complications compared to single layer closure? We used the PICO framework to conduct our study. The population are post-cesarean section women divided into 3 categories: pregnant women, non-pregnant women, and women with previous uterine surgery. Our intervention is double layer closure technique, and we want to compare it with the single layer closure techniques, and the outcomes are complications related to the cesarean scar defect and to infectious morbidity of the mother. We hypothesize that double layer technique results in lower incidence of complications compared to single layer technique. Our clinical implication is to contribute to clinical guidelines and protocol formation. We conducted our systematic search in 3 main databases, and our search key consists of 2 domains. The first one is basically refers to the cesarean section, and the second domain is refers to the technique. Our key articles have strengths and limitations. The first one, in the first one, the researchers waited at least 6 months before conducting follow-ups and required at least 2 millimeters for niche presence, producing more specific results. However, it is a single-center structure study, and some patients were lost to follow-up. Our second key article has a large sample size. However, too early follow-up was done in the healing process. And our third key article includes women in advanced labor, which is quite a bit of strength here, and unfortunately had a high dropout rate, and ultrasound examinations were performed not performed according to the menstrual cycle. Right now we are in the title abstract selection phase. We are basically finished with it. We just need to have a conflict meeting, and we can then move on with the full text selection. Our search key resulted in more than 9,000 articles, And after the duplicate removal, we are left with more than 6,400 articles, and we will have about 70 eligible studies after the title and abstract selection. My second project is comparing pregnancy rate after laparoscopic and open myomectomy. And we know that about 70% of women develop one or more uterine fibroid by the time they reach the age of 50. And fibroids have been linked both to infertility and recurrent pregnancy loss. And we also know that submucosal and intramural fibroids are the ones that influence pregnancy the most, the fertility the most. Traditionally, surgery for uterine fibroids requires open surgery, but laparoscopic myomectomy has several advantages like reduced hospital stays and less peritoneal trauma, which can result in decreased adhesion formation. Our aim is to compare the safety and efficacy of laparoscopic myomectomy and traditional laparotomy and to determine their effect on pregnancy rate after surgery. Our clinical question is, does laparoscopic myomectomy result in higher pregnancy rate compared to open myomectomy? And we used the PICO framework once again. Our population are women with fibroids. We want to compare the laparoscopic myomectomy with open myomectomy, and our outcomes will be the rate of pregnancy success after the operation. We think that pregnancy after laparoscopic myomectomy has a higher success rate than after open myomectomy, and we want to help clinicians in the personalized decision making. This is our preliminary search key, which also consists of two domains. Basically, the first one refers to the fibroids, and the second one to the procedure itself. All of our key articles fit our PICO framework. To summarize all this, we can say that we have two ongoing projects, and we plan to submit them by May and September of 2024. I would like to thank you for your attention, and believe you can, and you're halfway there, living with the words of Theodore Roosevelt. Thank you very much.
Congratulations to your presentation, Kincho. I would like to ask regarding your first project. Is the number of layers the only factor you want to analyze?
Thank you for the question. So we plan on doing a subgroup analysis because we found articles that say that both in the single layer closure group, they can use continuous locked or unlocked sutures, and we plan to look into that. And also, this refers to the double layer group. So in the first layer, they can use once again both locked and unlocked sutures, and this refers to the second layer as well. So
thank you.
Thank you.
Congratulations.
Thank you.
I'd like to ask about your second topic. We know robot-assisted laparoscopy is a very hot topic in the last few years. Mm-hmm. Are you planning subgroup analysis between robot-assisted and standard laparoscopic technique?
Right now, we just want to concentrate on the standard laparoscopic procedures. So maybe in the future somehow.
Okay, thank you.
In your first project, you mentioned about the cesarean scar pregnancy, and I wonder how viable it is.
So there are basically two types of cesarean scar pregnancies. Type 1 is the endogenic type, which progresses toward the uterine cavity, and it can be a viable pregnancy. However, it has a high risk of hemorrhage at the placental site. And the second type, type 2, is the exogenic type, which progresses toward the deep myometrial tissue or even the abdominal cavity, and that is not a viable pregnancy and has a high risk of uterine rupture and quite a life-threatening complications.
Thank you so much.
Thank you.
Thanks, Kincsi, for the very nice presentation. I have two questions. First, regarding your second topic. Do you plan to use any subgroups regarding maybe the location of the fibroids or any other characteristics of the population?
Yeah, we haven't discussed about that yet. Maybe that would be a good idea to look into that. Also, the number of the fibroids is quite an important factor. So, yeah, we will discuss it.
Thank you. My second question is that regarding your first topic, and I think this single versus double layer is like a decades-long debate. And why do you think the time has come now to put an end to this, or what changed? What do you think?
So I think with the investigation of multiple factors, we can put an end to this question. So our population is bigger. It's a more extensive population than I saw in the previous studies. And we also look at more outcomes. So maybe summarizing all this would lead to a conclusion.